something like that. Okay, there we go. Um, well, I wanted to say tonight, uh, Nicole King, Nicole King has agreed to return. We previously had a uh, session on reproductive rights. This is part of our series on freedom, democracy, and democracy in service, or Project 2025. And we had agreed not to record the previous session we had on this topic of reproductive rights. Nicole generously agreed to come back and uh, allow us to record this. So with that, I'm going to go ahead and turn it over to Nicole. And if you'd
Sure.
introduce yourself and take it away.
So like I said, I'm Nicole King. I am a critical care anesthesiologist, which means I'm both an anesthesiologist and an ICU physician. Now, I also have an interest in high risk obstetrics and spent about 3 to 4 years of my career taking care of pregnant women who had congenital heart disease or heart failure, who then we were actually in a pregnancy clinic for those patients, trying to establish if it was safe enough for them to continue pregnancy or not, and if it was safe enough for us to be able to deliver them successfully and keep both them and their fetus as safe as possible through pregnancy and then through delivery. Now, my interest in high risk obstetrics goes back to my time in the Navy. I was in the Navy for 10 years, and I was located at a large medical training facility. So we would get all of the high risk pregnancies throughout a certain part of the region. And so that's kind of where my love for high risk obstetrics came from. And I recognized two things: that everybody always talks about OB-GYN because they're obviously intimately involved in these patients, but the other people that are always there in circumstances such as these is anesthesia. And we should be just as involved and engaged in the advocacy around this topic. And I feel very strongly that way. Secondly, I recognize more than anyone, despite spending months and months in cardiac ICUs across the country and doing things such as putting patients on heart and lung machines through COVID, after all of that stuff, I still know the most potentially sick patient in a hospital at any time is a pregnant woman, because something can happen within seconds that can either negatively affect them or the fetus they are carrying. So that's kind of my background. I'm also a board member of the Ohio Physicians for Reproductive Rights, a group of physicians who came together after Dobbs and were instrumental in the passing of Amendment 1 last year in Ohio in 2023. We are very proud of that work, but also understand that the work continues, especially as we head into the elections in 2024, both from a federal standpoint, but also a state standpoint because of elected Supreme Court justices in the state of Ohio who will continue to uphold the rights that we voted in, and also help to prevent some of the restrictions around reproductive care in the state of Ohio. So, as we talked about last time, a lot of the things that I tend to talk about when I talk about this topic are kind of the things that people don't like to acknowledge. When I first started speaking openly about the amendment last year, obviously we all feel strongly that this is about autonomy of patients and reproductive rights. And a lot of our focus was on elective terminations of pregnancy, which is obviously a woman's right to choose, and we fully embrace that. But the other part of this that I would always try to focus on as well is this is not just about unwanted pregnancies, but is also very much about wanted pregnancies in situations and scenarios where the pregnancy needs to be terminated for the health or life of the mother, or because of a non-viable fetal anomaly, that a mother and their potential family members decide they would prefer not to carry to term or until going into labor naturally for various reasons. And these are the topics that I get very passionate about, because we tend to think that it's black and white. And I think as we know now, and as we see more and more cases come out, these topics are not black and white and are unfortunately on the front news, the front page of the news almost every day now, where we're seeing unfortunate stories of women, losing massive amounts of blood at home or in cars while waiting for the care that they need, because the physicians in these hospitals feel like they do not have the regulatory protections to make the right decision for the patients. So many people who have the opposing viewpoint say, yes, but these laws are written for the exception of the life of the mother. And what nobody understands is, what does the life of a mother mean? And how sick does that patient have to be before their life is in jeopardy? And that is a decision that is for a physician to make. But unfortunately, we have laws that try to dictate that decision, even though they don't think that they do, they do. And so physicians are paralyzed and feel like they're stuck between doing what's right for the patient and what's legal. And so many people will say, well, they should just do what's right for the patient and break the law. Well, the other part of that is, any physician who breaks the law and is threatened with court or jail time or having their license suspended has to also face the fact that everything they've worked for 10, 20, 30 years could be gone in an instant. And you would also take away yet another medical provider who's providing essential care to so many women who are in deserts where there's no reproductive care, because nobody wants to do this work anymore in those places, because there's this fear of litigation and, quite honestly, injury by people who don't agree with the type of work that they are doing. So I think for me, it's twofold. There is the concept of, when is a pregnant patient dead enough to consider them dead enough to warrant an abortion? And that sounds very stark and it sounds very abrasive, but those are facts. And so just today, as we shared, there is a case that is being presented as a reason that they should enshrine the rights of abortion in the state of Florida. And that story is being told on a commercial that is actually being threatened to be pulled off the air by an opposing political party. And this is a story of a woman who was diagnosed with stage 4 brain cancer when she was 20 weeks pregnant. And even though Florida has this law in place that says past 6 weeks, if a woman's life is in danger, then they can provide an abortion. But this woman was denied an abortion because, according to them, it would not save her life, but it would prolong her life. And that right there is a nuance that we as physicians who have been in this field long enough know is exactly the problem. Because is not every medical intervention we make for any human in the world prolonging life and preventing death, eventual death? Yes. And so this is where what they consider very black and white becomes extremely gray and becomes problematic for us to make the right decision for these patients. So this woman who's forced to carry a pregnancy and thus not be provided the care that she needs, such as surgical resection, chemotherapy, or radiation because of her pregnancy, could potentially accelerate the number of days that her life will be decreased, and also decrease the amount of time that she has to spend with her significant other and her child that is already here and born and is a toddler. And these are the stories that people say are rare, but those of us in this world know that they are not rare. And even if they are rare, this is exactly why these rights are so important to enshrine into law and to protect at all costs, is because nobody can ever know every situation that's possible. And anyone who's been in medicine long enough knows there will always be situations that stand outside, the normal boundaries of normal. And this is why medical ethics is a very gray area, because many of us have to come together to decide what is best for a patient in a certain situation at a certain time. And if you dictate that from a legal standpoint and threaten medical providers with jail time or a loss of their livelihood, we feel paralyzed and we feel as though we cannot do what's right for the patient. So that's in terms of what's happening, in terms of why we don't intervene when it seems like it's so obvious if it's for the life of the mother. Because it's not that obvious, because a woman who has significant high blood pressure disease of pregnancy or preeclampsia can be stable today and on death's door tomorrow. But everything in between it's a judgment. When is that patient sick enough to dictate, okay, now we need to induce early labor, which could then unfortunately lead to the demise of the fetus, which is actually viewed as an abortion if it's an induction of labor of a fetus that is pre-viable. So in order to save this woman's life between we're fine and she's dead, where in that continuum are you justified in either performing an abortion or inducing labor, knowing that the fetus will die? And these are the questions that those of us in high risk obstetrics have to answer and actually address all the time. And these are the things that people think are the rare exceptions. And they're far from rare, and they're far from clear cut. And every situation is unique. And allowing politicians and legal jargon to dictate when somebody is dead enough along that, continuum is where we feel very strongly that we are being constrained in how we can practice and actually, how do I say, honor the oath we took to do what's best for the patient in front of us. The flip side, or the other side of this, and something we talked about the last time we met, was we keep hearing these terms called post-birth abortions thrown around. And what nobody really wants to talk about, and those of us, again, in areas of medicine that deal with end-of-life care, such as I do in the ICU, is what we're actually talking about is palliative care of a infant that has a life-ending or life-limiting disease process who is not resuscitated at the time of birth, because palliative care has been offered to that infant's parents and family and their care team, and they have elected not to resuscitate and or do any interventions to prolong the life of the infant after it's born. This is a very regulated process that happens in high risk areas of medicine at higher echelons of care across the United States. If you look up neonatal palliative care, you will see that there are various organizations that have adopted very clear ways that you are supposed to do this. This is not something that's just done because somebody is pregnant at 40 weeks and then at 40 weeks plus one after they have the baby, they decide, no, I don't want the baby anymore. That's That's infesticide. That's murder. That's not what we're talking about. What we're talking about are processes and procedures that are in place for weeks to months prior to delivery, where it has been decided between this care team that includes maternal fetal medicine, pediatrics, neonatal intensive care, nursing, our nursing colleagues who are so involved in this type of stuff, the actual pregnant patient, their family members, if they would like, religious leaders, and other people who they depend on to make these types of decisions. This is a team that is created and formed around this patient, and they decide what's best in this situation. And so when people say, oh, they're allowing doctors to kill or let infants die in the delivery room after being born, what they're saying is that they don't think that we have a right to provide palliative care and not be forced to resuscitate neonatal patients at the beginning of life, which is the exact same thing as we could have done to us at the end of life. It would be the very same thing as somebody saying, I know you don't want to be resuscitated, but unfortunately, that's illegal. So, regardless of your wishes, we are going to intubate you. We are going to pound on your chest if your heart stops. We are going to defibrillate you. We're going to give you medications. We're going to put you through numerous dozens and dozens painful procedures just to prolong your life. And anyone who doesn't think that these are the same thing doesn't understand medicine, because these are the exact same things on two different ends of the lifespan of a human. I would also state that some people will say, well, that's very dramatic or an exaggerated example, but this is not, because at the very beginning of the chapter on the Department of Health and Human Services and Project 2025, it specifically states that abortion and euthanasia are not medical care. And people say, oh, well, euthanasia is like doctor assisted suicide. And that's actually kind of what that term used to mean. But really, all euthanasia means is that you are allowed to either remove or not provide life prolonging or life sustaining measures if it's against the wishes of the patient and their loved ones. And so we are going to be walked into a situation where physicians, patients, and the people on their care teams are no longer allowed to make the decisions that's best for the patient at that moment in time. And when an infant is born with what they call life limiting disease process, because this terminology is very calculated and has been decided upon by bodies that are formed and filled with physicians and professionals, and they actually have terminology in there that says life limiting fetal anomalies, meaning it's either a lethal anomaly or an anomaly that would not be able to be overcome without egregious and prolonged interventions that may or may not actually be effective. And sorry, my cat's right there. And so that is kind of where they have taken something that is so beautiful and thought out, a way to provide a process of closure and mourning that can be the only small blip of something good in a very terrible situation. And they're taking it away and calling it something that it's not, which is this concept of a post-birth abortion. And I feel as though there's not a lot of people out there talking about this because a lot of people don't understand this. What happens in the delivery room is and what happens with these patients is often a lot of even physicians and nurses are not exposed to this world. People don't understand what do not resuscitate orders mean. They do not understand what end of life like wishes mean. A lot of physicians who don't deal with this stuff on a daily basis don't even understand that this stuff is happening every day across the country. So it's understandable why there's not a lot of people out there talking about this. But there are a few of us, and we want to kind of shout it from the rooftops that what they're trying to do is take away our ability to not only care for a pregnant patient, but care for a terminally ill infant. And that's why it's so important for us to take this matter back into our hands as physicians and medical providers. And it's not that we don't think that there should be laws and limitations around the things that we do, because I will always say that politics are always deeply ingrained in what medicine can or cannot do. Of course they are, because we ask the government for a medical license and we have to follow rules and regulations in order to continue to get a medical license. So there's at no point in time are we saying that politics and our political process is not going to be a part of medicine. Those are not facts. We are intertwined and integrated. What we want is we want an ability to use our professional expertise, our training, and our oath, and use it to the best of our ability to optimize the safety and wellness of the patient in front of us, even if that is not something that is protected in a court of law. And that's why we want to take the power back into our hands and allow to have the freedom to care for the patients in front of us. And that was a lot of information. And I'll kind of
Right.
open it
Very
up from
good.
there.
Good. Couple questions. That case in
Mhm.
Florida that you spoke of, it was at 20 weeks that she was diagnosed. The pregnant woman was diagnosed with brain cancer. Correct me if I'm wrong, but I believe that in Ohio right now, um, she could have gone ahead and had her abortion. And
Correct.
um, because in Florida it's 6 weeks, here it's the dividing line is fetal viability, correct? And
Correct.
as I remember, the earliest that a fetus has ever been uh, viable was like 21 weeks and 6 days. I did a little study on that myself. So
Yeah.
are most of the abortions, to your knowledge, happening that way in Ohio right now?
Oh, no. I mean, those types of abortions are so rare. I mean, like they're,
Oh, you're speaking of after 21 weeks, or
yes,
yes, okay,
right. Yes.
right,
But at
right,
the same time, are those situations happening in Ohio? Absolutely.
sure,
And I've been there, because
yeah,
20, that's where a lot of people don't understand is that time frame is very tricky in patients who have significant disease processes, because that's
hmm
when patients' bodies are really starting to change to support the pregnancy. And unfortunately, that's also right when you get a lot of testing back, and you start to see if a pregnant patient is going to be able to tolerate or handle continuing pregnancy. And so
hmm
that's why the wording of the Ohio law is so important, because it says up to fetal viability, but then it also very clearly states, but unless for the health and the wellness of the mother. Because that's where we really need to make sure that we allow for that wiggle room, and that we're talking about the health of. Because when you say for the life of, things to people don't know what that means. And so when you enter into that post viability period where things get gray, 22 and a half, 23 weeks, we can support a fetus outside of the womb at that point in time, but there's a lot of questions that go into that decision that a pregnant patient and their care team have to determine for themselves. And I think that's why the wording of these laws is so important, because those of us who are trying to pass these laws to enshrine this right into state rights while we wait for the federal government to try to undo what they've done is we allow for flexibility in our wording because we recognize the need for that gray area.
Right. And just to bring up an example, if that woman in Florida, if she were in Ohio, and let's say they diagnosed her at 24 weeks with brain
Mhm.
cancer,
Mhm.
then I assume in Ohio even physicians would be reluctant. They
Yeah,
they
and I
they
think
would,
that that's yes, I mean reluctant because I
yeah,
think though there would still be a discussion of so then the discussion becomes termination of pregnancy versus induction of labor. Those
right,
are two different things. Meaning induction of labor with the goal of delivering a live fetus and allowing for full resuscitation and intervention, which could be their decision. The flip side, though, is that that's going to have to take into a lot of different situations of what's best for the patient. But you're exactly right. Is once you get to that point of viability, it's a much different question, especially if the fetus doesn't have any associated life altering anomalies. But
right.
this is why it's so tricky, right? And this is why these situations need to be discussed out loud. And we
Mhm.
need to allow for flexibility because exactly like what you're saying, every single one of those little nuances makes a difference in terms of what's legal and what's not legal.
Right. And I would just like to mention this is why the names Donnelly, Stewart, and Forbes should be put into everyone's minds. They are the Democratic candidates for the Ohio Supreme Court, and they are in favor of um, reproductive freedom, basically. These decisions that are being made. So remember those names: Donnelly, Stewart, and Forbes. Um, and we have Matt here tonight. Matt is uh, an expert now on Project 2025. He's been listening, he's been studying. In fact, he's been invited to speak on Project 2025. Is there anything uh, in addition you'd like to say, Matt,
Um,
regarding that?
First of all, thank you so much, Nicole. This has been really informative. I really love hearing you speak on these topics. Um, this is not necessarily going to pertain directly to anything that we've been discussing tonight, but it's how they're going to do it. Um, if you look in the requisite pages of 2025 to see what they say about things like, you pointed out abortion and euthanasia are no longer considered healthcare. And, there's a lot of other stuff in there. There's a lot of stuff about mifepristone and medical abortions and how they want to get rid of that stuff. And the way that they are going to do this, I've said before that they don't need Congress to do any of this stuff. They have set it up so Donald Trump, if reelected, can essentially do all this stuff by executive order or by something called Schedule F, which is what they talk about when they talk about getting rid of all the non-political appointees at various government agencies and replacing them with political appointees. So all they need is somebody at the head of the FDA that is going to say, well, the policy of the Trump administration is we don't believe that abortion is healthcare. So we are not going to allow dispensation of mifepristone. So they don't need Congress. They don't need votes of anybody. They've set all this up so they can do it on their own. And that's is and should be for all of us that love democracy and human rights. We should consider that to be a really, really dangerous thing.
Absolutely agreed. I read most of the Health and Human Services chapter and took notes at the same time, and my notes were laced with profanity because it was so ridiculous and
Mm.
overwhelmingly egregious. especially as it pertained to even so much as pertaining to uh, asking like the CDC to encourage and enforce the rhythm method of birth control,
Right.
talking about the health risks of hormonal birth control, talking about the health risks of elective abortions, the registry for abortions, which they truly want to make, especially if you've had an adverse outcome. This whole concept of um, uh, people traveling across states, for abortions and all the things they want to do to patients
Right.
when they come back to the state. And it kept getting more and more concerning. And what I really thought was interesting is, yeah, there was some other topics in that chapter, but it always came back to abortion
Right. Exactly.
every single time. The whole chapter, 90% of it was about reproductive rights. And that's the part that's so scary.
Unbelievable. Yes, and people can read that. You can download it. Project 2025, Bold Democracy. We have it on our website, boldbloomdemocracy.org /project 2025. We have a lot of information about it there. So be informed, folks. This is an extremely important topic. You want to know a lot about it. Any other thoughts, Matt, or questions?
No, I already voted today, so I'm
Okay.
doing my part. But I just want to
Yeah.
thank Nicole again. That was a great presentation.
Thank you very much again, Nicole. And
Of course.
anything else you'd like to say before we?
I mean, I guess just to kind of like close the loop, as the care of patients in my ICU is something that I hold so dear. I am a physician who withdraws care. I take away heart-lung machines. I extubate or take breathing tubes out. I give medications to comfort patients that can potentially hasten, death, because that is allowed when actually performing palliative care, because you are treating the patient understanding that the treatment could hasten or shorten the amount of time that it takes for a patient to pass. That privilege of providing that care for those patients and that family is the most important part of my career as an anesthesiologist and an ICU physician. To me, it's the most important part of my career, because for all the things I can do to save somebody, the most important thing I can do is allow them to die with dignity. And I cannot even imagine how strongly physicians who do this on the other side of life feel about this. And that's what I really want people to understand, is you're taking away the dignity of our patients, and you're ripping away our ability to do what we want to do most, which is care about patients.
All right. Thank you so much, Nicole. And we're so much better off with physicians like you out there. Thank you.
Thank you.
I'm going to go ahead and stop the video here. And second.